Inclusion crisis for neurodiverse children in school. Let's start with few definitions first. ASD.
Autism spectrum disorder, ASD, is a developmental condition that affects communication, social interaction, and behavior. It varies widely in how it appears in individuals, and early support can greatly improve outcomes.
ADHD.
Attention Deficit Hyperactivity Disorder, ADHD, is a neurodevelopmental condition characterized by inattention, hyperactivity, and impulsivity. It can affect a child's focus, behavior, and ability to regulate emotions in daily activities.
Learning disability including dyslexia, reading difficulty, dyscalculia, math difficulty, dysgraphia, writing, spelling difficulty.
Learning disability is a neurological condition that affects how a person receives, processes, or expresses information. It can impact skills like reading, writing, math, or comprehension, despite having average or above average intelligence.
Speech and language delay.
Speech and language delay is a developmental condition where a child takes longer than expected to develop speech or understand and use language. Early identification and therapy can significantly improve communication skills and overall development.
Down syndrome.
Down syndrome is a genetic condition caused by the presence of an extra chromosome 21, leading to developmental delays and distinct physical features. With early support and inclusive care, individuals with Down syndrome can lead fulfilling and meaningful lives.
The silent crisis.
India is currently facing a silent crisis in inclusive education, particularly when it comes to neurodiverse children. Despite policy frameworks such as the Right to Education Act, 2009, and the RPWD Act, 2016, mandating inclusive education, the ground reality paints a starkly different picture.
The crisis are lack of early detection, scarcity of trained professionals, social stigma and isolation, inaccessible curriculum and pedagogy, therapy and support cost. Let's understand them one by one. Lack of early detection.
The diagnosis of neurodevelopmental conditions such as autism, ADHD, speech delay, or learning disabilities is often delayed until after the age of 6. This is problematic because critical brain development happens between ages 0 to 6. Early identification allows timely speech therapy, occupational therapy, and behavioral support, improving long-term outcomes. Due to limited awareness among parents and pediatricians, and stigma surrounding disability, warning signs are often ignored or misinterpreted as bad behavior or late blooming. In rural areas, there is near complete absence of developmental screening tools or trained child psychologists.
Impact. Children miss the early intervention window, leading to a widening developmental gap by the time they enter the school. Scarcity of trained professional.
Mainstream school teachers in India are often not equipped or trained to handle neurodiverse learners. Special education is rarely included in foundational teacher training programs like B.Ed or D.Ed. Teachers may not know how to manage sensory needs, communication delays, or behaviors common in children with autism, ADHD, or intellectual disabilities. Schools may lack resource rooms, special educators, or learning support staff.
Result. Even if a neurodiverse child is admitted to a regular school, they often remain unsupported, misunderstood, or eventually pushed out. Social stigma and isolation.
Our societal attitudes toward disability and difference remain highly stigmatized. Children with special needs are often seen as abnormal, spoiled, or difficult. Parents fear social judgment and are sometimes discouraged from seeking help. Schools may deny admission or subtly push out children who don't fit in. Peer bullying, lack of empathy, and absence of inclusion policies further isolate neurodiverse students.
Emotional toll. This leads to low self-esteem, school refusal, and mental health issues in both children and families. Inaccessible curriculum and pedagogy.
Most Indian schools, preschools follow a one-size-fits-all teaching model, with limited flexibility in teaching pace. Learning styles, assessment methods. The concept of universal design for learning, UDL, which promotes multiple means of representation, engagement, and expression, is largely absent from curriculum planning. Furthermore, textbooks are not adapted for dyslexia or cognitive differences. Classrooms often lack visual aids, AAC devices, or sensory-friendly tools. Exams prioritize rote memorization over comprehension and creativity.
Consequence: neurodiverse children struggle academically not because of lack of intelligence, but due to inaccessible delivery methods. Therapy and support cost.
Access to professional support is both limited and expensive in India. A single session of occupational or speech therapy can cost 500 to 2000 rupees per session in cities. Children often need 2 to 4 sessions across multiple therapies for years. Very few government-run centers offer free or subsidized services. Special educators, clinical psychologists, and child therapists are in short supply, especially in Tier 2 or 3 cities or rural areas.
Financial burden. Families are forced to choose between therapy and household survival, resulting in fragmented or no support. Let's see how first world countries address this inclusion.
Countries like Finland, Canada, the UK, and the United States are far ahead in addressing neurodiversity in education. Early screening programs are integrated into pediatric care and preschool systems. Individualized education programs, IEPs, are legally mandated and monitored. Schools employ special education teachers, behavioral therapists, and inclusive coordinators as part of standard infrastructure. Parental advocacy and state-funded support services are widespread, reducing the burden on families. There's a growing cultural shift toward celebrating neurodiversity, not just accommodating it.
#Micro School Model. We're a school within a school.
Avian Idris Bridge School is a bold, community-rooted initiative designed to address this inclusion gap, starting with early years, where intervention or acceptance matter the most.
Our educators are trained in inclusive pedagogy, child psychology, and assistive communication. Why Bridge School? Inclusive, not isolating.
Bridge School aims to integrate neurodiverse children into mainstream settings, unlike special schools which often isolate.
Family involvement.
Bridge School actively engage parents and caregivers through training sessions, interactive workshops, and home-based programs, and often invite them to participate within the classroom as well.
Flexible and individualized plans.
Each child receives a customized learning plan, unlike rigid one-size-fits-all models.
Real-world exposure.
Encourages blended learning at home, in school, in community, for better generalization of skills.
Short-term dependency, long-term independence.
The focus is on bridging developmental gaps, especially in activities of daily living, ADLS, to empower children with greater independence and confidence.
Collaborative model.
Foster a collaborative ecosystem by bringing together educators, therapists, psychologists, and families to support each child holistically.
Our vision and mission. We don't just teach, we advocate, collaborate, and adapt. Our mission is to bridge the gap between the child's unique learning needs and the societal systems that are yet to evolve. While the journey toward inclusive education is still evolving in our country, we are committed to leading by example, by building our own inclusive model of support and learning. Foundation laid.
We began our journey by partnering with a preschool in Kharadi, Pune, launching our first academic year pilot. This hands-on experience offered deep insights into the gaps from both the schools and parents' perspectives.
Inclusive learning begins.
We initiate curriculum adaptations and individualized education plan, IEP, tailored for neurodiverse learners. This phase marked the beginning of structured support and measurable developmental goals in the classroom.
Strengthening the model.
We refine our curriculum based on real-time feedback and learning outcomes. Simultaneously, wheel the formal process to apply for NEOS Center accreditation, enhancing coverage after preschool.
Scale for inclusion.
With proven success, we expand our model to 10 schools and preschools across Pune. This milestone reflects our commitment to making inclusive education accessible and replicable at scale.
#where we spend. Our fund utilization is strategically planned, 45% towards core team salaries, 30% for technology and platform development, 15% dedicated to outreach and marketing efforts, and 10% reserved for contingency and ongoing R&D.
Pledge your support, donate now. Thank you.